recording now, and the recording will be distributed after this webinar. At the end of the webinar, we have allotted some time for questions and answers, and we will address questions that were sent prior to the webinar and also address any new questions that you can enter by typing into the panel on the right of your screen. So please save any questions for the end of the webinar and enter it in at that time when we let you know. And any questions that we are unable to answer during the time allotted for this webinar, we will address in an FAQ document that we will circulate after this webinar and will be circulated to all of you. Now, without further ado, I will turn it over to Lynn Wagner, who will give an introduction to this webinar.
Great, thank you, Julianne. Hi, I'm Lynn Wagner from the Wake Forest School of Medicine and Wake Forest Baptist Comprehensive Cancer Center. I co-lead the ECOG-ACRIN Cancer Control and Outcomes Program, and on behalf of ECOG-ACRIN, I'd like to welcome you to this webinar on patient-reported outcomes research to be presented by Dr. David Cella. Before we begin, I'd like to thank Julianne Herman and Brenda McAllister-Affleck from ECOG-ACRIN and Mary O'Connor from Northwestern for all of the behind-the-scenes work that has made today's webinar possible. Also, some of the research that you'll hear about today is supported by the DCP, DCCPS, and CTEP, and we thank the NCI for support and collaboration. Dr. Cella is chair of the Department of Medical Social Sciences, Ralph Seal Poffenberger Professor at Northwestern, and the director of the Center for Patient-Centered Outcomes in the Institute for Public Health and Medicine. He has authored or co-authored over 700 peer-reviewed publications, and he was one of the first to champion the integration of patient-reported outcomes in the cancer clinical trials system. Of his many accomplishments, it's one of the most noteworthy in recognition of his work to measure and apply patient-reported outcomes in healthcare. Dr. Cella received last year's Gustav Leinhardt Award from the National Academy of Medicine. As a brief background on today's webinar, Dr. Cella recently gave an excellent presentation on patient-reported outcomes research during the ECOG-ACRIN group meeting. Many of our colleagues expressed an interest in attending, but were unable to do so given schedule conflicts. Dr. Cella graciously agreed to deliver his presentation as a webinar with the goal of providing our colleagues with guidance on PRO design in the context of cancer clinical trials. The webinar announcement was initially circulated to ECOG-ACRIN, NCTN, and NCORP members. However, the email announcement sharing the opportunity to hear Dr. Cella present spread quickly, thus we're anticipating a large audience today. And now it is my great pleasure and an honor to introduce Dr. David Cella.
Thanks, Lynn. Is the audio okay? I guess Lynn or Julianne can let me know.
Yeah, you sound great, David.
All right, and I think I'm controlling the slides, so let's get started. We lost a little time. I apologize to everyone on the call for having to wait a little bit. No, I'll try to make up some time so we have some time for question and answers. I unfortunately might have packed a little too much in, so if I breeze through, forgive me. I want to be sure to have time at the end for some conversation. The outline here on the left is lessons from history. I'll talk a little bit about, things we've learned over the years, some surprises, update on PROMIS, update on FACT and FACET, and then PRO-CTCAE, and then talk about some emerging issues on the horizon. And just one more confirmation. Are you now, let's see, are you now looking at disclosures? Lynn?
Yes.
Or Julianne? Okay, just want to make sure that everyone else is seeing what I'm seeing. Okay, so I have several grants from NIH that relate to PROMIS, directly on PROMIS and also distribution of PROMIS, and I'm president of FACET.org, so those are my disclosures for the presentation. I want to talk about the place for PROs in cancer research, just give a little background, a little history, and how we've learned some things somewhat accidentally. But to set the stage, and this is mostly focused on non-curative cancer, but of course there are also as a place for quality of life evaluation in curative trials as well. But progression-free survival has become the main endpoint in most clinical trials, and that's because subsequent therapies, there's so many available subsequent therapies in so many solid and liquid tumors that overall survival has become a somewhat contaminated endpoint where you don't necessarily see a survival advantage, and yet you get a progression-free survival advantage. And that sets up questions that relate to the patient's experience of treatment and experience of life, you know, with and after treatment in terms of disease symptoms, side effect burden, tolerability. Cost comes into play because so many treatments now are becoming long-term, and patient treatment preferences come into play. So it's become very important, and more important than ever, to be able to understand if all we know is that we can lengthen life, perhaps improve response rate, are we really making lives better? Because we can't be sure with so many of the new therapeutics that we're lengthening life itself, but we can be pretty confident that we're lengthening the time of life where one is free from progression. That doesn't necessarily mean one's living a better life. So that's where the quality of life angle comes in so many studies. There are some design considerations I wanted to open up with. One is when you're designing a trial, you know, it's really important to understand the natural history, so far as we understand it, of the disease you're working on, that would be, what's your expectation for the control arm or the comparator arm in a comparative trial in terms of response rate, disease-free survival in the case of curative therapies, or progression-free survival, or overall survival? And what's the expected relative benefit of the new treatment? Of course, then also on the other side, what's the expected toxicity of both arms? Keeping in mind that, you know, most trials in oncology are not blinded trials. And there are factors such as experimenter demand, placebo effect, nocebo effects, which is the effect of negative expectations on outcome reporting from patients, and then patient preferences that come into play in terms of tolerability and you know, willingness to take on toxicity in exchange for the possibility of benefit. And all of these factors need to be considered when designing not just what to measure, and I'll talk mostly about what to use when measuring quality of life, but the timing of the quality of life and how far out you go. So some lessons from history that I wanted to touch on, and really kind of on a theme of serendipity and observation. I think history has been a great teacher. So much of what we've learned has not been what we went into a study to evaluate. Very often, you know, typically we go into a study to evaluate whether the new therapy is associated with better quality of life than the existing comparative therapy. And very often, I say more often than not, the answer is no difference. You see so many studies come out with no difference in quality of life, and people might then think, well, we didn't really learn anything by adding that quality of life data, and I'm going to try to impress upon you that, you know, we have learned a lot from doing these studies over time. Here's an example, actually, where there was a clinical difference. This is an old study. This is the original Taxol study where cisplatin etoposide was compared to 2 different doses of Taxol, one with growth factor support combined with cisplatin. So cisplatin was common across all the treatments, and what was varied, of course, was adding paclitaxel or Taxol back in the early 90s. We published these results. This was a positive study for Taxol, which got it launched into the treatment arena in lung cancer. But there were no quality of life differences between the treatment arms. So that, along with so many other studies that have that same kind of story where there's a clinical difference and the quality of life is not different between groups, leads some people to say, oh, well, quality of life isn't responsive or sensitive, it's not picking up the benefits, or perhaps to say maybe the benefit to on the treatment of the disease is offset by the added toxicity of the treatment, and that's important to think about. But we learned, something in this trial, which is, this actually got presented in an ASCO plenary session, that baseline quality of life, and that was not new information, baseline quality of life is a strong predictor of survival in advanced solid tumors. But also early change was even more predictive and added to that predictive ability of baseline. So how patients do in those first 2 cycles of therapy tells us a lot about how they're going to do in the long run. This is the top green line here, patients who started with better than the median quality of life and actually had improvement at 6 weeks after 2 cycles. And the bottom blue is our patients that started below the line, the median, and actually worsened in those first 6 weeks. And the survival differences in a lung cancer context, where this kind of difference between groups is pretty large, caught the attention of of a lot of people. We also used that study where there were no quality of life differences in the face of a treatment difference to start to understand what's a meaningful change on the brief set of symptom scores on the lung cancer subscale of the FACT-L. And this is just one example where around 2 to 3 points were associated with patients who were responding in those first 12 weeks, keeping in mind that this is even in the face of toxicity. So they're being given platinum and taxane or etoposide toxicity, but they're actually showing benefit in their lung cancer symptoms in those first 12 weeks, when they then went on to show, best response to therapy. So this kind of information, merging the quality of life data with the clinical data, helps us understand, not just that the data are valid, that patients, have valid information in terms of predicting survival with how they report their symptoms and tracking with clinical change, but that we can then start to use this information to define responders in subsequent work. This is a little bit later than the ECOG trials, the IDEAL studies with ERESA. Mark Chris was the lead author on this. This is a paper that showed that, a study that showed that patients who, even in the first 4 to 6 weeks from randomization, were later subsequently identified as partial responders, the blue group, were already showing that symptom improvement. The dotted lines here, the dotted white lines, are indicating that 2-point change that we were looking for, 2-point benefit. So while the progressive disease patients, didn't really improve very much, except in the very beginning at 2 weeks. Something peculiar to ERESA that nobody's really fully understood. But then they just kind of flatten out and don't really show much improvement to their symptoms, unlike the partial responders. So this actually helped influence the regulatory review of ERESA in those days. Another registration trial, the AXIS trial, which is axitinib and sorafenib in kidney cancer. This is an axitinib registration trial, looking at 15 items from the kidney cancer version of the FACT, and showed that while there were no differences between axitinib and sorafenib on the sort of overall FACT kidney score, the symptom index score, at the end of treatment, in the yellow circle here, at the end of treatment, there was on average 6 points worse scores on this questionnaire compared to the average of the on-treatment period here between axitinib and sorafenib. At the 1-month follow-up after treatment, there was actually some recovery, probably indicating a lessening of toxicity. So from the end of treatment, where patients come off, some for toxicity, most for disease progression. But it starts to tell us that 2 things. One is that it is good to be on treatment, generally speaking, and patients that come off treatment either for toxicity or for disease progression are considerably more symptomatic. 6 points on this particular set of questions is a big number, and that some of that is recovered in the 1 month following cessation of therapy prior to the introduction of new treatment. Most of these patients went on to some new treatment. So again, learning a lot about how the patients experience treatment, whether they're willing to tolerate toxicity in the face of the questionable efficacy value in their given individual case. I'm circling here, this is the 15 items that were used in that questionnaire. I've circled here, I'm bothered by side effects of treatment, because I want to go into another kind of area that later on that. That was one question in that I mentioned the side effect issue, that some of that drop was because of toxicity, and that question is right in there. I'll come back to that symptom side effect bother question in a moment. This is another almost ancient study from 20 years ago, looking at erythropoietin versus supportive care in myelodysplastic syndrome. Another case where there was not a difference in treatment between erythropoietin and supportive care, partly because it wasn't a very large study. But there was a huge difference in fatigue and overall quality of life when you compared responders to non-responders. So the so-called responder analysis, although it's retrospective and not the unit of randomization, it is revealing and informative to us about, you know, what meaning to make of these scores. So they're not just numbers. They start to tell us things like, well, responding patients have fatigue benefits that are around 5 points more than non-responding patients, and that's a helpful piece of information when you carry that to future studies. I'm going to shift a little bit now to a study that Lynn Wagner led with Brad Call, and this is E4402, which is a lymphoma study, and they compared maintenance rituximab to a strategy of retreating with rituximab when there's evidence of progression. And again, a study where there were no differences in treatment. And the interesting thing, which actually was good because it can be reassuring about a retreatment strategy that can reduce the cost of Rituxan use in treatment in a chronic sense, that it's okay to wait in this patient cohort for retreatment as opposed to continuing on with maintenance therapy for a potentially unlimited period of time. But the interesting thing that Lynn studied here was looking at anxiety. She was very interested in the idea that, you know, maybe people are anxious when you stop Rituxan and sort of, quote, make them wait until there's a progression, sort of walking, you know, the sort of walking wounded or worried well, if you will, concept. But she found no differences in anxiety between the two treatment arms, which also was reassuring that this is not something that's sort of psychologically harmful or need to worry about. But she did find that people that had an avoidant coping style did have more anxiety and lower quality of life. So to people that say you really should only study symptoms and function in quality of life studies, then you'll hear that recommendation from various places. I would say, you know, I would not necessarily agree with that, especially if there's a theoretical or good hypothesis behind the reason for, in this case, looking at things like anxiety and avoidant coping style, that it does help clinicians to think in terms of, if this is a person who doesn't like to look at information and prefers to kind of, you know, turn a blind eye to it, they may be more at risk for being anxious in the downstream treatment period. So let's move on to breast cancer. This is another lesson learned in an NCI Canada trial, MA27, that ECOG-ACRIN participated in. Actually, a lot of groups participated in it, NCI, CCTG, SWOG, COGB. These are all the old names of the groups, et cetera. This was a large open label anastrozole versus exemestane aromatase inhibitor comparison study, and there was a sub-study, E1003, which is an ECOG-ACRIN study that also was led by Lynn and looked at FACT endocrine symptoms comparing the two treatment arms out at not just baseline, but 3 months, 6 months, 12 months, and 24 months, and got pretty good compliance out to 24 months in this particular study. These are some of the sample items. It was a 46-item assessment that used the FACT-G, but also breast cancer-specific and endocrine symptom-specific questions. And the primary endpoint was a set of 23 endocrine treatment-related symptoms, looking at treatment-emergent symptoms. Again, a study where there were not treatment arm differences in terms of the treatment emergent symptoms between anastrozole versus exemestane, so it's not going to be the basis for deciding which one is better for quality of life. They seemed like they were equal in that regard. But getting back to that side effect question, one of the things that we discovered in the data was that the patients who said that they were somewhat, quite a bit, or very much bothered by side effects at the start of therapy, at baseline, were more likely to discontinue therapy in the period of time, in the months following therapy. It was a pretty significant p-value and hazard rate and Kaplan-Meier curve difference. So this was submitted at the San Antonio meeting in 2011 and is being submitted for publication almost as we speak. It lends some credibility or validity to this single bother by treatment side effects. I mean, treatment side effects are a very big concern. I'm going to come to the PRO-CTCAE soon. Before that, just give one more example here from in prostate cancer, enzalutamide versus placebo. And enzalutamide was significantly superior clinically to placebo in terms of time to progression. It was also better in terms of time to first deterioration of health-related quality of life. I'm showing this because it's become a fairly typical way in advanced cancer of looking at treatment arm comparisons, that is plotting in the same way with a survival analysis approach, a time to deterioration of quality of life. To do that, you need to know what is a deterioration in an individual patient, and that's where some of those earlier studies have helped inform us about what number to use to classify a patient as having deteriorated. And here you see that placebo patients get worse at a much faster and significantly higher rate than the enzalutamide patients. I would say over the years, this approach, this time to deterioration approach, was more, has been more fruitful than attempts that we and others have made to analyze longitudinal data with, that have not ignorable missingness with things like pattern mixture models, which are promising and can be informative, but often, at least in my experience, have not been that different than the mixed effects models that are vulnerable to bias, when you have non-ignorable missing data. So this approach has seemed to emerge as a more frequently used approach, although some of us are still trying things like pattern mixture models and multiple imputation methods. This is from the same study. I'm sorry, this is the AFFIRM trial. And looking at the FACT-P total score, another emerging way to show data and by then to sort of visually then interpret data. This is just showing at every possible change score, comparing FACT-P total scores on enzalutamide in blue to placebo in red, and you can see pretty clearly that regardless of which change score you might select for the FACT-P for worsening, or for improvement for that matter, enzalutamide shows superiority to placebo at week 13, week 17, week 21, and week 25. You have to pick a point in time to do this analysis because you're just asking how many people have worsened or improved by that particular number. That's what this plot illustrates. Okay, so that was just hopefully a rapid tour through, I guess Cella Quality of Life Town in the past 30 years, with some of the lessons learned and how I think we've gotten a lot of information that we can use going forward. But now I want to talk about some assessments that are available resources for your research. And this is not, I know there are a lot of people on the webinar that are not in the cancer area, and this was really a cancer-focused presentation, but PROMIS certainly is a set of resources that can be used in any disease area, and to a lesser extent the others I'll talk about as well. So the overview of PROMIS is that there have been more than 40, it's pretty close to 50 different research protocols over the last 12 years aligned with evolving PROMIS standards. It's included more than 60,000 people that have contributed data. When people talk about PROMIS, it's important to keep in mind that it's really, it is adults and children, but it's not one thing. It's 1,400 questions in adults that populate 81 banks and 462 questions for kids that populate 20-item banks. And it's in many different languages, most prominently English, Spanish, Dutch, and German, but that number that is expanding rapidly, as rapidly as we can manage actually into many languages and availability. And I'll give you a website URL later if you don't have it already that you can go and find out what's available in what languages. It covers universal concepts. Universal is a rename of generic because, I guess we thought that universal just sounds better than generic in a medical context, meaning that there are some things that are important to all people, and we would rather start with the assumption that if you're measuring something like fatigue or pain or physical functioning or depression or anxiety, that it's a better proposition to measure that common across diseases as opposed to having disease-specific measures of each of these things. That leads to more confusion in the field. So we started from that universality type approach to, and then working then now to expand it to specific areas as needed in a disease-specific kind of framework. So as of this month, there are, last check on clinicaltrials.gov, at least 81 trials on clinicaltrials.gov that are using PROMIS measures. And Lynn invited me to write a paper on this. So the TBW means to be written in cancer. So there will be next year, if it gets accepted, a review paper on PROMIS in cancer. This is the website URL, healthmeasures.net. It's really the source for PROMIS information and access. It is easily navigated, thus the easy button. And I'm not going to say too much about it, so we can kind of get to the rest of the substance I wanted to be able to cover. In healthmeasures.net, you can do all kinds of things. You can see the list of available measures, the tools, the scoring instructions, guidelines for interpretation, list of publications, available data sets that you can download and analyze and write your own papers on, upcoming workshops and events, basics on measurement science. There's an interactive forum, so you can ask questions or answer other people's questions. And then the most popular section on the Health Measures website is the search and view measures, where people go and download PDFs and also get demo videos and learn about implementation options, administration options to them. This is the basic framework. As I mentioned, there are 80 adult and 20 pediatric banks, but they all get classified as either physical health, mental health, or social health into these basic component branches of symptoms and function and affect, behavior, cognition, social relationships, and social function. There is a global health, a 10-item global health measure that kind of is an umbrella over all of it. So the typical measures, they're almost all derived from item banks. They use computerized adaptive testing, which is a dynamic approach that averages 4 to 6 questions per domain. So it's very brief, but also very precise, very accurate. You can download fixed-length forms a little bit, for the sort of quick and easy use. You can do that by individual domain or by health profile, and then I mentioned that PROMIS Global 10. This is a view of the profiles. So the profiles cover 7 of the most commonly downloaded or interested domains on the mental, physical, and social health side. So there's some representation of each of these domains of health. There's also a 0 to 10 pain intensity question. So the 4-item versions of each from each domain times 7 is 28, plus the pain question makes the PROMIS 29. If you use the 6-item versions together in a profile, it makes the PROMIS 43, and the 8-item versions make the PROMIS 57. So these are sort of easy off-the-shelf profiles, a little bit analogous to SF36 or even something like FACT or EORTC in the cancer context. It covers somewhat different domains, but a lot of similarity. This is just a visual on the computerized adaptive test approach, where you can get high precision with covering a wide range of a trait by starting, and sort of in the middle with an assumption that, maybe this person's kind of where most people are, and then zeroes in on exactly where they are with a selected set of questions using information that we have about each item, so to sort of pick the next question in a smart testing approach. The metric is a T-score metric with a mean of 50 and a standard deviation of 10. It's reference to the U.S. general population in almost all cases. Sometimes it has to be referenced to a clinical population, but typically it's referenced to the U.S. general population. You can find out about all that specificity on the website. So I've been getting a question lately quite a bit. I appreciate it because people are, I guess, giving me a chance to, educate them. And part of why I thought it might be good to do this webinar is I get this question, so, you're doing PROMIS, you did FACT. Should I be switching from FACT to PROMIS? And I imagine others get asked that or ask that question. And I don't see it that way. I think they're complementary. There's some things where they're even identical. In the last week, I've been asked twice about people that have been told they should use PROMIS fatigue and not FACIT fatigue. That's one of the commonly used FACIT questionnaires. And I explained to them that, interestingly or coincidentally, the FACIT fatigue questionnaire is embedded within PROMIS fatigue item bank. So 13 of the 95 items in the PROMIS fatigue item bank are the FACIT fatigue. So Interestingly, if you use the FACET fatigue, you're actually using a 13-item short form of the PROMIS fatigue item bank. And we try to achieve that kind of identicality, or at least equivalence, whenever possible, so that we can compare across FACT and EORTC, FACT and PROMIS, EORTC and PROMIS, et cetera. So both are possible, and I'm going to talk about designing, studies in terms of, what to choose and when, without overburdening the patient. I'll show you some examples of how, how you can think that through and not feel that you have to be sort of fixed in the structure of the legacy questionnaires, like in this case FACT. And the future really is hypothesis-driven customization. I think you probably know what I mean by that term. I just kind of made it up last night when I was finishing the slides, but you can customize your study based upon your hypotheses and then do an appropriate follow-up assessment of the validity of that approach downstream. So in terms of FACET as an assessment resource, many of you know this, at least working in cancer, but others, it was developed more than 20 years ago. It has these 4 subscales: physical, social, emotional, and functional. It's actually about more than 50 different questionnaires that cover various disease-specific measures. So it really takes the opposite approach as PROMIS. It comes from a disease-specific approach and symptom and treatment-specific approach. So that's why they can be nicely complementary. Cover different symptoms like fatigue, diarrhea, cognition, treatment satisfaction, even spiritual well-being. And it's available in more than 60 languages. And there's a website, facet.org, you can go to for more information. There we go. We start with that FACT-G, which is 27 questions, and then add disease-specific questions, and that can end up being 40 to 45 item-long questionnaires that used multiple times can be burdensome, and if you try to add other things to it, can make people say, do I really have to ask all of it? So for that reason and others, regulatory-wise, we shorten the many of the FACT scales into these symptom indexes that end up being more like 10 to 20 items long for these 11 different advanced cancer types, and there have been probably about 20 or 25 publications across these 11 and more to come. So it's a way to think in terms of if you want to stay in the FACT realm, ask 10 to 20 questions, you can go to a symptom index approach and still have room for other questions, whether it's PRO-CTCAE or whatever. This is an example for ovarian where we have the disease-related symptoms here in green, an emotional question here in yellow, and then treatment side effects in blue, and then sort of a general function and well-being in the peach. And these were all developed using FDA kind of endorsed, if you will, methodology to make sure that we're asking the most important questions and coming up with this symptom and side effect and general function-oriented 18-item ovarian cancer index. Another way to sort of stay with the FACT system but not be burdened by having 40 items is you could say, well, gee, Cella's group has published a couple papers now on this FACT-G7, which is a rapid 7-item short form of the FACT-G that takes the top 7 symptoms and concerns and adds them into a score that actually correlates quite highly with the overall FACT-G. So if you want an estimate of group estimate of quality of life, you could ask these 7 questions, and there's a lookup table to compare it to the FACT-G. And you're also asking about important things like fatigue, nausea, sleep, pain, and worry, and general quality of life. And it actually performs pretty well in terms of Cronbach's alpha being in the 0.74 to 0.81 range across 4 different samples. The minimally important difference range in the 2 to 3 point range, and has comparable validity with the FACT-G, and these are published with the references below. This is just a set of questions on how they're laid out. So, you can consider this for use in your trial, and then you really have lots more room to do some of the other things you want to do specific to your hypotheses. I said I'd come back to this bother with side effect thing partly because the FDA has gotten very interested in this and wants to be able to take something like PRO-CTCAE results and be able to sort of put them on the scale together and say, well, at the end of the day, treatment A's got, XYZ side effects, and treatment B's got, PQR side effects, and they're different, but how do we know which one is rougher on the patient? And this can be kind of a a way to determine that. So we went to validate it, and this is now in Press in Cancer. It's actually out in e-publication. I can send it to you if anyone that wants it. Looking, for example, at maximum adverse event grade, whether that's 0, 1, 2, or 3, 4, and what was the average GP5 score. And you see that as the grade goes up, so too does the average score on that one question about burden. So it's clearly tracking with maximum adverse events, also tracks with number of adverse events. People that say they're very much bothered on average have 6 to 7 adverse events reported. People that say they're not at all bothered have more like 2 or 3. So it tracks in a logical way. It also tracks with people's ability to enjoy life. So those who say, 75% of people who say they're not at all bothered by side effects of treatment are saying they're quite a bit or very much able to enjoy life, whereas only 40% of people who say they're very much bothered by treatment are able to say the same thing. So it's got the kind of validity we look for. It also tracks with the EQ5D utility score with a difference of around 0.14 to 0.15 units. All of this coming out in this paper in Cancer. So I've been talking about kind of disaggregating things a little bit here. You probably picked that up, symptom indexes and that single item on side effects, et cetera. Well, there is now a searchable item library for FACIT where you can actually go into this library, which has 775 items across adults and peds, and search by either PRO-CTCAE domain, symptoms, function, general health perceptions, various keywords, and by language. And you can view those measures. You can create custom measures using an item wizard, and then you can register to use it. This is just an example, so you can go in and click on symptom, and then after you click on symptom, you pick one of them, in this case fatigue. And if you click on fatigue, you'll see the 13 questions, which happen to be the FACIT fatigue. You could pick 3 of them and create the form like this, and then you can ask those 3 questions. In this particular case, because these are calibrated items in the PROMIS fatigue bank, you could actually get a PROMIS fatigue score out of these 3 questions that you might have picked because they're specifically the kinds of fatigue questions you want to ask in your given trial. So this is a different kind of flexibility than we've really ever had before, whether through PROMIS or through a searchable item library like this. Another great resource that's with a searchable library is the PRO-CTCAE. It covers about 10% of the 800 adverse events that are in the CTCAE version 5. And it increases the validity of adverse event reporting, particularly with symptoms that are best understood by asking the patient how bad it is. And it's designed to be a companion to the CTCAE to capture patient experience of toxicities in trials. It covers 78 adverse events drawn from the CTCAE, and you can customize surveys the same way I just described with the searchable item library, paper or electronically. Validity, responsiveness, and mode equivalence have been demonstrated, which is excellent, and it's available already in 15 languages, and more coming, as I understand it. So this is a look at the site. You can go to have to look. You got the URL here, and it's also at the end of the presentation. And you can go to it and learn more about it and see the languages that are available, download PDFs, create a custom form, and then get permission to use. It's pretty easily navigated and used. Okay, so now I want to kind of wrap up with just talk a little bit about some emerging issues, and I'll kind of breeze through these, and so we have some time for questions. One emerging issue in oncology is long-term oral treatments. This is, a relatively new thing. It brings up questions of tolerability and adherence that are, the last 10 years, increasingly important and going on now into the next, few decades, I think will be, especially as we see that even with aromatase inhibitors, 30 to 50% noncompliance after several months, or at least certainly a couple years of therapy. High rates of people deciding they've had enough. Immunotherapy is obviously a very important issue, particularly with the diversity of adverse events. one of the questions that came in, I may as well answer now, is there a set of items for this? And we, with various other groups, Aaron Hansen in Toronto, and Adam Dickler, Thomas Jefferson, Heather Jim, Monica Jonda in Australia, some of you may be on this call, are pulling together a sort of a master set of immunotherapy toxicity items. Basket umbrella trials is a big emerging issue, not just because of the opportunity to do precision medicine phenotyping, which is really exciting, but also to study all those people who find out they're not eligible. For every one person that finds out he or she's eligible for a trial or for a new drug, there are scores who find out that they're not. High drug costs is obviously a big issue, and that ties in with value-based decision-making and increased patient copay. These are issues that tie in with patient-reported outcomes, but really need to extend into other ways of inquiring, not just about symptoms and function, but preferences, insurance arrangements, coverage issues, et cetera. Common metrics, I've only touched on that a little bit, but common metrics that things like something like PROMIS brings to us can enable better communication about things like fatigue and pain, and start talking about a common number. It can help comparative effectiveness research, where you can bring different sample data from different studies into one common metric. Treating to PRO targets based on standard settings. So we've learned a little bit about, or quite a bit really, about what's a meaningful difference, what's a meaningful change. Treat people to hit those targets and get more input from patients and other stakeholders that are closer to the ground than clinical researchers might be is emerging as well. Finally, custom trial design with item libraries, as I mentioned, whether the PRO-CTCAE or the FACET item library, ORTC has one as well. I'm not sure if it's operational yet, but it's coming. So you can do hypothesis-driven item selection, and the only thing I qualify there is that when you go in and sort of pick and choose what makes sense in your particular trial study based on your hypotheses, it is important to have kind of a background validation plan for your strategy, just to make sure that you're getting coherent information. Finally, this is about the sort of common metric idea. I do believe, and I think we've started to show this, that PROs can be increasingly considered more like something like blood pressure. We have many different ways of measuring it, but one metric, and we ought to be compelling ourselves, particularly with things like fatigue and pain and depression and physical function, some of these common big-ticket domains, to have, to move toward one metric. Rosetta Stone is a way to do that. You can go to the website, and so on the last slide. We've already identified pairs of instruments that have sufficient data to analyze. We've rejected some of them because they don't meet the assumptions for linking, but then we've completed links for 53 pairs of instruments across 18 subdomains, so you can actually go to the website and see a lot of lookup tables already crosswalking from one instrument to another, often to PROMIS. So maybe there's a better way with common measures, common metrics. Envision a big tent of research in a community like this. I see almost 300 people on the call, and thinking of people as people, or patients as people, and not the diseases that they have. And if you do that, if you think of patients as people, we all tend to have the same symptom experiences and function, and we may express them differently. We may have different value sets that that create preferences for one or another, and we ought to be doing what we can to understand that. But the domains themselves are common. So thank you. Those are my 2 cents. These are lots of websites here, but just to run through them, there's a health measures website for PROMIS and other systems associated with it. The Rosetta Stone site, if you want to look at the links. The FACET site, if you want to look at the searchable item library or just download tools. The PRO-CTCAE website for you to download and use that tool. And then there was a SWOG symposium last year where a lot of these issues were discussed, not just by me, but by others like Ethan Bosch, and that's still on on YouTube. So go give it some hits, and we'll take some questions. Thank you very much.
All right, everybody, this is Julianne, and I just wanted to instruct everyone how to enter their questions. There's a Q&A panel in the right-hand corner of your WebEx. So feel free to enter any questions into there. And I know we're coming close to the end of the hour, so any questions that we are unable to address, we will address after this in an FAQ document. And how this is going to work is that I'm going to read through the questions in the order that they came in, starting with questions that were sent before the webinar. So the first question for you, Dr. Cella, is, what is the difference, if any, in implementing PRO research outcomes in pragmatic versus explanatory trials? Any considerations we should think about when designing such trials?
Yeah, I'm going to try to be real brief so we can get through some of these. I think the special considerations here are blinding, which is likely not the case in most of these studies, and whether or not you're using informed consent in your study, and then these sort of placebo and nocebo effects that can studies can be vulnerable to when you don't have blinding and equipoise. So I would say those.
Great. What opportunities are there for CCDR studies that study the facilitators of the use of PROs in routine care delivery at community cancer centers?
Well, this is an exciting new area. The NCI is very interested in this with the whole term of cancer care delivery research. I think there are some funding announcements on the street right now, and I hear there are more to come. So. I think I would check with NCI on that, but this is really good timing for that.
Are there any opportunities to become involved in a musculoskeletal pain committee or working group?
Yeah, no, I can't tell if that's cancer specific or more generally, like with orthopedics or rheumatology, but there are musculoskeletal interest groups in rheumatology as well as in orthopedics, and they're actually quite active with regard to PROMIS in particular. And I can connect the questioner, depending upon what we're talking about. In the cancer setting, I think we'd have to do a little research on that to see if there's a specific musculoskeletal pain group available.
What PROMIS evaluation seems best to determine pain and disability relief following spinal manipulation?
Well, maybe this is too easy, but I would say pain and physical function. I mean, I would go to the practice and say, what else do you care about? But those seem to be the two obvious ones.
How can other established web-based systems that capture PROs access research funds available at PCORI?
Well, I mean, of course, see the PCORI website, but I will note that maybe a lot of us did, but I got a letter from Joe Selby, which is kind of like a big blast letter that said, we're still open. Anything we fund this year and next year will be funded through the course of what you propose. We have the money to do it. So they're very encouraging about, to anyone who might be thinking PCORI is going away, this letter said, not yet, at least. So, I think I have the impression from that letter that maybe applications are down and this would be a good time to go in.
Great. I'm a pain physician at Stanford Pain Center and am interested in learning about how you use your registry for clinical care and research.
Okay, well, you must know Sean Mackey, whoever's asking the question. Sean runs the Choir Registry, which is a Stanford Pain Registry, so I assume the Stanford Pain, maybe I shouldn't, is involved in that. We don't have a registry like that. So I think I would refer you back to Choir.
How might this apply to home care?
Well, I would say that the PROMIS banks cover the low end of function and symptoms really well. So you can go into one of the PROMIS banks and look at something like physical function or other functional areas and identify questions that are really very very basic, or as we say, easy physical function questions, being able to get in and out of a chair to bed or from chair to bed, et cetera. But we don't, I'm not aware in PROMIS of anything that relates to sort of home care, satisfaction, et cetera. You probably are, maybe best off looking at some of the CAPS work there.
Are PROs being developed for real time, such as digital display? And if so, has a standard platform been agreed upon, and who is building it?
Yes, to the first half of it, but there is not a standard platform. There are multiple vendors who are building, and have and are building some things like PROMIS into their systems. You can use and we have an API that's available on the website. So I'd say there's not a standard system, which is too bad in a way, but at least it's, you could make the argument that it's encouraging innovation to have multiple vendors.
What progress to date has been made in getting PROMIS into regular, i.e. integrated, use in large U.S. HMOs?
Well, there are large health systems that are using. So the Kaiser Northern California is sort of all in on PROMIS. Some of the other HMOs are waiting for Epic to get online with the CATs, which has happened this year for PROMIS. So I'd say, the Epic expansion into computerized adaptive testing, which is very popular in individual clinical assessment, which is really how you get clinical adoption for individual patient care, not so much for group data, which is more of a research interest. So I think it's still emerging, but there are some examples, and then there are some large health systems like Partners in Cleveland Clinic and others, that have kind of drunk the Kool-Aid and are all in.
Great. Are there recommended instruments for population health-focused work, including areas such as infant mortality, diabetes, morbidity mortality, substance use disorder, and complex care?
Wow. So there is more broadly than that. The PROMIS Global is recommended by and now deployed by CDC as a Healthy People 2020 and hopefully also 2030 goal for the nation. So that would be the 10 questions in the PROMIS Global. In terms of infant mortality, I would actually refer you to ECHO, which we're also involved in, where we've just gone through a process of identifying sort of standard measure set and common data elements for for that. So if you send me an email, I can connect you with the person who can get you that information. What was another one? Diabetes? What were the other ones?
It's infant mortality, diabetes, morbidity mortality, substance use disorder, and complex care.
So diabetes, I would probably go with the global and then just sort of shop around. Substance use, there's a whole set of item banks in PROMIS on substance use. And complex care, CMS is kind of recommending either the global, the 10-item, or the PROMIS 29. I have a little bit more of a favoring for the PROMIS 29, to be honest, and building out from there because it captures more domains. I mean, complex chronic conditions and complex care management is, by definition, can't be disease specific, or you'll go crazy. So you really do want to benefit from these more universal approaches.
So we have 1 more minute left, so I'm just going to ask the final question, and any questions that we were unable to get to, we will address in the FAQ document after this. So the final question is from this webinar. We keep hearing that the EMA prefers anything but PROMIS because they are not familiar with the PROMIS approach. Can someone put this right, please?
Well, I never heard that, so I don't know who keeps hearing it, but whoever asked it keeps hearing it. So I think you have to email me and let me know, who you are and who you're hearing it from. I know that there's a lot of demand. It's mostly coming from the providers, not from the EMA, tech people. But I don't know. I think I need to hear more about the resistance to help.
All right, so we have reached the end of the hour. It is 1 o'clock, and I would like to thank everybody for joining. Stay tuned after the webinar, and I will circulate the recording from this webinar along with any questions that were unable to be answered. And I'll open it up for Dave and Lynn to have any closing remarks.
Great. Thank you, Dave, for a wonderful presentation.
My pleasure. Thanks to everyone for joining. It's a big crowd, and I'm very honored to have this time with you. Thank you.
All right. Thank you, everybody. Have a great day.
Go out and do good things.
Thanks.
Bye.